Onc Live Insights is a video editorial program produced by Onc Live.
One of the other oncogenic drivers that's been described, principally in adenocarcinoma of the lung, are alterations in B-Raf. The most common one is the V600E, which is very similar to the alteration we see in metastatic melanoma. Obviously, knowing that this is present in 1 to 2% of B-Raf patients, the use of B-Raf inhibitors, both dabrafenib as well as vemurafenib, have been studied, and there is a clear level of activity. The initial data with dabrafenib in B-Raf mutant patients with V600E showed an objective response rate of about 35 to 40%. That data has matured a little bit, and that response rate has kind of held in the 30 to 35% range. Like in melanoma, the dual inhibition of both B-Raf and MEK with the addition of trametinib has been a successful strategy in melanoma that has been studied in non-small cell lung cancer. In successive cohorts, this was not a randomized trial, but if you look at the initial dabrafenib data with a response rate of about 30 to 35%, the combination study using dabrafenib and trametinib actually had a response rate of about 65%, so about double the use of dabrafenib alone, mirroring some of the data in melanoma where the combination appears to be superior to the single agent alone. Now, most of this has been studied in refractory disease. We have just finished accrual to a first-line, previously untreated cohort of B-Raf mutant patients using that combination. And so I think that with further study, this is a very attractive approach. Again, it follows the theme, like we've seen in EGFR mutations, ALK, ROS, down the list. B-Raf is now on that list. If you're a practicing oncologist, you need to think about B-Raf, and you need to test for it, because, again, these targeted agents, targeting B-Raf plus or minus MEK, that data will mature and we'll know. It may be a very effective strategy for these patients with known B-Raf mutations. So again, it adds to the list of things you have to think about as an oncologist in managing adenocarcinoma of the lung.
B-Raf mutations are very common in patients with melanoma, and we've heard a lot about targeting B-Raf mutant melanoma. What's less known is about B-Raf mutant non-small cell lung cancer. B-Raf mutations happen in about 1 or 2% of patients with non-small cell lung cancer. Importantly, only about half of those are the key B-Raf V600E mutation. The other half are inactivating mutations that are a little bit less well understood. So approximately 1% of patients with lung cancer have the B-Raf V600E mutation. As with melanoma, the first way to evaluate patients with B-Raf V600E is to look at single-agent B-Raf inhibitors. So both dabrafenib and vemurafenib have been explored as single-agent B-Raf inhibitors in patients with B-Raf mutant non-small cell lung cancer. Response rates for these drugs are in the 30 to 40% range, which is certainly good, but it only is rivaling first-line chemotherapy. And we will always want to do better for our patients with oncogene-addicted cancers. We want to do better than conventional chemotherapy. At ASCO this year, we saw some very exciting data that showed that the combination of a B-Raf inhibitor, dabrafenib, along with a MEK inhibitor, trametinib, led to significantly higher response rates, a response rate above 60% for patients with B-Raf mutant lung cancer. So I think this really transforms B-Raf from being an interesting niche to something that we really have to identify and target going forward. So I think B-Raf mutant lung cancer should be identified as part of any initial screen for patients with lung cancer. B-Raf should be part of the oncogene panel that you do for your patients with non-small cell lung cancer. We learn more and more about individual subtypes of lung cancer. Some of these are rare, 1 or 2%, but it's really important to identify these because we do have targeted therapies that can help these patients. Sometimes these therapies are even more effective than chemotherapy and even more effective than the immunotherapy we hear so much about. One relatively uncommon but important subtype is RET rearranged lung cancer. RET is something we typically think about when we think about thyroid cancer, but about 1 or 2% of patients with non-small cell lung cancer have RET gene rearrangements. These rearrangements are important in driving the cancers. If we look at it in laboratory models, we see that these RET rearrangements can cause cancer in these models. Now, when we identify this in patients, then we have to think about how we can treat them. There aren't a lot of significant RET inhibitors, but there are drugs that do have activity against RET. And cabozantinib is a great example of a drug that targets a number of kinases, but RET is one of them. One of my colleagues, Alex Drillin at Memorial Sloan Kettering, has done a prospective trial in which he enrolled only patients with RET-rearranged lung cancer and evaluated their response to cabozantinib. What he found is a response rate that's above 30% for those patients with RET-rearranged lung cancer, suggesting that cabozantinib is a very real option for those patients.